everyone, and welcome to your final lecture. This is going to be on GI disorders, and the best thing is that it is not included as part of your final exam. This is only a complimentary lecture, especially those students who are planning to work in the space of clinicals. This would be useful for you to listen. All right, so I'll just start. So yes, these are your learning objectives. And I'll start with the main content. So gastritis. So basically what is gastritis? It is inflammation of the inner lining of the stomach. And why does this happen? One of the key reasons being infection by Helicobacter pylori. All right, so this is a bacterial infection. This bacteria is resistant to your stomach acidity, and therefore it can keep growing. All right, this infection is the one which is responsible for inflammation of the gastric lining. All right, and once your gastric line is inflamed, this can lead to various other conditions such as ulceration. So you have ulcers in the stomach, which is called as gastric ulcers, and we'll be talking more about that. If the gastric ulcers are very big and very deeply embedded in the stomach, this can even lead to gastric cancer. All right, and then you have issues such as chronic gastritis as well. Okay, and the other say signs and symptoms of Helicobacter pylori infection is achlorhydria. What is achlorhydria? It is no HCl production. Okay, meaning the gastric acidity production is affected. As you know, your stomach has an acidic environment, and HCl is what is synthesized or produced by the stomach, that is affected. And you know, calcium requires an acidic medium for its absorption, and therefore calcium absorption will be impaired. Helicobacter pylori also affects your intrinsic factor, and your intrinsic factor is important for your B12 absorption. Therefore, B12 absorption will be impaired. And as you know, the classic sign of B12 deficiency is pernicious anemia. Okay, so these things are more food science. Then you have Helicobacter pylori infection, which directly affects iron absorption as well. Okay, and the main source of this bacterial infection or the bacterial contamination is contaminated food and contaminated water. All right, and the treatment is heavy antibiotics. Okay, so basically this is one of the key reasons for gastritis. Of course, you have other reasons as well. For instance, you can have, say, chronic alcohol consumption, smoking, and genetic, conditions as well. So there are many, many reasons, but one thing which is very common is the Helicobacter pylori infection and its impact. Therefore, this has been covered. Then you have, say, peptic ulcers. Okay, so now peptic ulcers, under the canopy of peptic ulcers, you have your stomach ulcers and you have your duodenum ulcers. All right, so now with your peptic ulcers, again, what are the causes of your stomach or duodenal ulcers? They are your Helicobacter pylori infection. There are certain drugs or medication, meaning drugs, that can cause these kind of peptic ulcers, which is your non-steroidal anti-inflammatory drug, NSAID, aspirins, corticosteroid, meaning steroid-based medications. Then you have metabolic stress. What do I mean by metabolic stress? When your body is under a catabolic condition. Catabolic condition when there is excessive amount of protein breakdown and loss and less amount of protein regeneration or synthesis. Okay, this happens during, say, severe burn patients, GI surgery, major accidents like motor vehicle accidents, renal failure, chemotherapy, radiation therapy. These are metabolic stressful conditions. Okay, of course, then you have chronic alcohol consumption and also smoking, which I mentioned earlier. And with smoking also comes tobacco chewing, because with tobacco chewing, it increases your inflammation, local and systemic inflammation. It decreases your bicarbonate ion secretion, which is happening in your small intestine. It also decreases, say, or impacts HCl secretion in the stomach. All right, and of course, it also impacts your blood flow, the nutrient flow, which should be supplied to your gastrointestinal tract. Okay, so these are the basic causes of peptic ulcers, which comprises of your stomach and duodenal ulcers. So now, guys, of course, please be mindful that this is a complimentary lecture, and you may have medical images. I haven't, say, highlighted everywhere that there are medical images, but if you're not comfortable, please be mindful about it. Okay, so yes, you have duodenal ulcer. So as you can see, it is in the duodenum. The duodenal ulcer, gastric ulcer would be in your, say, stomach. So this is how they look, okay, through an endoscopy view. This is your pyloric sphincter, which connects your stomach to your duodenum. All right, so this is how the ulcers are situated. So now the general differences between the two ulcers, as the name goes, gastric ulcer, it happens in the stomach, duodenal ulcers in the duodenum. With gastric ulcer, the stomach pain is 1 to 2 hours after eating, or some individuals may experience pain as soon as they eat. Okay, so there is a variation. All right, so now with duodenal ulcers, definitely the pain is once the food starts trickling into the duodenum. All right, so when you have your food in your stomach, it gets churned and it turns into something called as bolus. So when the bolus starts trickling into the duodenum, that is when you will experience pain with duodenal ulcers. All right, so the pain is 3 to 4 hours later generally, because at least the food in your stomach will stay for 2 hours minimum. All right, depending upon the type of mixed diet which you have. All right, so yes, with gastric ulcers, as I said, sometimes you may feel pain as soon as you eat. So it is not something which can be relieved by eating. With duodenal ulcers, sometimes patients feel that when they eat, the pain is relieved. All right, because the focus is more towards the stomach for food digestion rather than, say, food absorption, which happens in your small intestine. So yes, a temporary relief you may find by eating with duodenal ulcers. Now with gastric ulcer, one of the classic sign is hematemesis. So what is hematemesis? It is when you have blood in vomiting. Okay, that is called as hematemesis. So basically with gastric ulcers, the blood is quite fresh. Right, so it is very bright red in color, hematemesis. Whereas with duodenal ulcer, you have melena, which is blood in stool. So now remember, when the ulcer is, say, bursting, or it has ruptures, or it has say any sort of tear, and that is when the blood is trickling from the ulcer. That is the blood. Okay, so now in the duodenum, if the ulcer has ruptured and you have, say, blood loss, so this blood has to go through the duodenum, through the ileum, through the jejunum, all of those, then through the large intestine, from large intestine to the rectum, anus, all of that. Okay, so all of the pathway. So by the time it comes out in the stool, the blood is not fresh. It is quite dark red in color, maroonish sort of. So therefore, there is also a color differences between gastric and duodenal ulcer, the blood. All right, gastric ulcers, they can lead to gastric cancer. All right, as I said, because the underlying cause of gastric ulcer could be something like Helicobacter pylori infection. And with gastric ulcer, guys, if it penetrates, or if it ruptures the stomach bag, then these ulcers may start, say, pressing on the other organs which are surrounding the stomach. Okay, and therefore this can lead to gastric cancer. All right, duodenal ulcers, generally, most of the time, they are not associated with cancers. Okay, but yes, gastric ulcers are more likely at an epidemiological level that they are associated with cancers. Okay, then you have gastric acid secretion. With gastric ulcer, it could be an increase or a decrease of gastric acid secretion. Again, it depends upon the underlying cause of the gastric ulcer. If you have a gastric ulcer because of Helicobacter pylori infection, it is very likely that you will have less HCl secretion, all right? Whereas if it's some alternative reason, all right? With duodenal ulcer, your bicarbonate acid secretion is definitely affected, because as you know, bicarbonate acid secretion, it happens in your small intestine. Duodenum is the first part of your small intestine. Okay, so your bicarb secretion definitely decreases, and you have in proportion to that, the GI secretion is much more higher. Okay, so you have a lot of GI secretion in the duodenum, but you do not have a lot of bicarb ion to neutralize that acidic secretion, and you don't have an acidic environment in your small intestine. And this can further aggravate the duodenal ulcer because it is becoming more acidic in nature. Okay, so then you have, say, these are, guys, please remember, GI management, nutritional management, like any other disease, it is very complicated in nature. So this is not meant like, from a dietetic point of view for you to train you as a dietitian. This is just a general overview. Okay, so what are the dietary management support that are generally offered? So with gastric ulcer, as I said, intrinsic factor is lowered or it hampers intrinsic factor secretion. So B12 absorption may be impaired. Therefore, you may need, say, B12 vitamins. And it all depends case by case basis. Okay, so I'm not saying that this happens for all patients. This is just a generic overview. Then you have low HCl secretion and gastric acidity. It supports the absorption of calcium, iron, but now that is impaired. So you may need, say, vitamin and mineral supplementation. Then for example, if you have gastric ulcers because of Helicobacter pylori, you may have nutrient absorption because this directly impairs Helicobacter pylori infection, directly impairs the absorption of all of the nutrients, iron, B12, calcium. And of course, the same thing applies if the ulcer is in the duodenum. This will impair the absorption of, again, all of your micronutrients, vitamins, and minerals. Okay, so now certain myth busters. So what they say is, if you have, say, basic foods like your milk, cream, protein foods, they act as buffer in the HCl secretion. But please remember, protein food, it will, say, stimulate pepsin secretion in the intestine, gastrin secretion as well, okay, in the stomach, meaning HCl secretion. Proteins will be broken down into amino acids in the stomach. Okay, so basically, there is, it is not that if you have these sort of food, like if you're having a burn, you have milk, and this is going to, say, calm down your burn. It is not like that. Because ulcers have, as you have seen, a very different pathophysiology. Basically, yes, when your bolus starts trickling into your, say, small intestine, it will stimulate bicarbonate secretion. And this bicarbonate secretion will be a true acid buffer, okay, because your bicarb ions are neutralizing your acidic environment, meaning the HCl secretion from the stomach. So yes, that is a true buffer, but it is not that these foods create a magical basic environment or a alkaline environment in your stomach, and therefore they prevent the ulcer or they heal the ulcer. Those things don't happen. Okay, then you have another myth that acidic food causes, say, gastric ulcers. Acidic food meaning foods which will have lower pH. For example, like oranges, the pH may be, say, 3.2, 3.6. But remember, your HCl, the pH of your gastric acidity, your gastric HCl is much more lower, anywhere between 1 to 3. Therefore, it is not that the acidic, say, pH of the food is, say, causing gastric ulcer. All right. And basically, the amount of oranges which you consume per se is not, say, enough to, say, cause an ulcer. Okay. So, but yes, especially if you have mouth ulcers or ulcers in your, say, esophageal tract, food tract, that is when, say, you may find it soothing to not have acidic food, because they may cause the burn, they may cause that irritation and inflammation if the ulcers are in the mouth or esophagus. Because your mouth doesn't have an acidic pH, your esophagus doesn't have an acidic pH, right? Esophagus doesn't have a secretion of anything. All right, so basically that's why acidic foods, if you have oral ulcers or esophageal ulcers like esophagitis, inflammation of your esophagus, that is when they can be irritating. Okay, but once your food goes into your stomach, the pH is very different. So it is not that acidic food causes gastric ulcer. Okay, or else, say, milk and things are, say, buffers to gastric ulcers. Those are myths. All right, then you have, for example, alcohol. Yes, alcohol, as you know, you have learned in the liver lecture that this will increase your inflammation of your GI tract. All right, and this can lead to, say, gastric or duodenal ulcers. Caffeine and tannin, basically, they are not directly related to, say, erosion of your, say, your GI tract, but it can increase, say, your gastric acid secretion, and therefore it may be much more painful in gastric ulcer. Okay, so yes, that is there, that caffeine and tannin, these kind of substances, they may increase HCl secretion in the stomach, which can therefore be difficult in either gastric or duodenal ulcer. If you have a lot of GI secretion, and if it is going to, say, gastric secretion, acidity secretion, if it's entering your duodenum, that again will cause trouble. Okay, then you have, for example, spices. So now spices in very large amounts. Okay, so like supplements of, say, black pepper or chili, on things like that. This can say probably say irritate. If you already have a gastric ulcer, okay, this can cause damage to the inflammatory tract. Not that if you have a healthy GI tract, it is highly unlikely that these say supplementation can cause irritation or inflammation. But say for example, even if you have say black pepper supplementation, if you have things like that, you know, which are available in the market, they always tell you on the bottle how much should be consumed, all right, for a normal healthy individual. If say you're having say 10 black pepper supplements, imagine the amount of black pepper which is going into your GI system. That will certainly cause inflammation. Or else if you already have say gastric or duodenal ulcer, and then you're having these kind of say spices, this may definitely aggravate the inflammation or else the uneasy symptoms. Okay, then you have, for example, curcumin, which is there in turmeric. That is an anti-inflammatory agent. And there are few studies which have shown that it could be effective against Helicobacter pylori. But of course, there is no level 1 evidence per se. Okay, then you have various foods which have shown to combat Helicobacter pylori infection. These are like your fermented food. It's like your sauerkraut or kimchi. Okay, then you have your green tea, and then you have your veggies, which are more alkaline in nature, if you learned about acidic and basic ash. Okay, so yes, these foods, there are many individual researches which have shown benefits of these, or some studies which have shown that no, there was no significant difference. So there is no conclusive evidence, but yes, some things may work for some patient at a clinical consensus level. All right, then you have supplements, for instance, again, no consistent result, but as we have seen the benefits of omega-3, it is an anti-inflammatory agent. Therefore, it could be useful in say gastric or duodenal ulcer, which basically is an inflammatory condition. Okay, then we go on to inflammatory bowel disease, which is your ulcerative colitis and Crohn's disease. Causes of this are not very much known, guys. Majority of them revolve around genetic susceptibility, autoimmunity. Okay, so there is no like clear cause of this. And basically, the consequences where you have inflammation of the intestinal tract. Which area exactly? This is what the diagram covers. So just look at my mouse over here. So in Crohn's disease, you have inflammation in patches, and they could be anywhere from mouth till your anus. Okay, so for instance, there could be patches of inflammation in the large intestine, small intestine, stomach, mouth, anywhere. That's Crohn's disease. Okay, so again, under IBD, you have ulcerative colitis. And in ulcerative colitis, the inflammation is in the colon, so the large intestine, all right, and it is predominantly very likely to be seen in the descending colon, all right, the last part of your intestine. Okay, then you have what are the rough differences? So as I said, ulcerative colitis, inflammation can be anywhere. So ulcerative colitis, sorry, inflammation is in the large intestine, the colon, especially the descending. Crohn's disease, inflammation anywhere. So ulcerative colitis, inflammation is continuous in nature. As you can see in this diagram, it's all red over here, okay? So it is continuous in nature. Crohn's disease, inflammation is in patches. So you have healthy area patch, it's like that. Ulcerative colitis, highly likely that you may see melena, which is blood and diarrhea. In ulcerative colitis, the wall of the colon, they become very, very thin. And when the wall is thin, guys, this increases the risk of deep embedded ulcers. And whenever you have deep and embedded ulcers, this increases the risk of cancer. Okay. Then you have in ulcerative colitis, you may have no strictures at all. What is stricture? It is narrowing of the tissue because of scarring or inflammation. I'll show you a diagram of it. Then you may have few or no fistulas. Fistulas again is like a tunnel which is formed between say your GI tract. I'll again show you diagrams of that. And the look of ulcerative colitis is like P pseudopolyops. Polyops is like these round knotted structures. So your say colon, the inner wall of your colon, it looks like this round knotted structures, polyops. Okay, so over here, as you see, you have in Crohn's disease, you generally do not have bloody diarrhea. Okay, melena, you may have bouts of diarrhea and constipation. Okay, depending upon which part of the intestine is inflamed. Generally in Crohn's disease, you have thick intestinal wall. Whenever you have thick intestinal wall, meaning highly likely that you may have strictures, you may have fistulas. all right? Because of thick intestinal wall, the ulcers are shallow, they are not very deeply embedded, okay? You may still have cancer risk. Malabsorption, generally what I have seen in clinical cases, it is there in either cases, okay? So malabsorption is in either cases. Cancer more likely with ulcerative colitis, but you can't disregard Crohn's disease and cancer, okay? There are still places where you may see that. The appearance of Crohn's disease, the inner intestinal wall is like cobblestone appearance. And now I'll show you medical images for the same. Okay, so now guys, this is the normal intestinal tract. This is the normal brush border. Okay, our normal brush border which we have. There is no villus atrophy taking place. If you remember villus atrophy from your allergy lecture. Okay, so yes, this is how you have an endoscopic view of a healthy intestine, okay, which you and me have. All right, so now for example, with Crohn's disease, which as I said, the inflammation, Crohn's disease, you can have inflammation in patches anywhere from your mouth till anus. Okay, so you see your intestinal wall is thickened. With thickness of intestinal wall, the ulcers are not deeply embedded, but you have high risk of strictures and fistulas. We'll see an image of that. This is the cobblestone experience, the visual. Okay, guys. Whereas with ulcerative colitis, you have P pseudopolyps. All right, so these are your P pseudopolyps, the inner wall of your intestine. Okay, and these are your thin walls, and the ulcers could be deeply embedded as well. Okay, so yes, guys, basically this is how it looks, and this is what the condition is. All right, now these are your stenosis, guys. Okay, so you have thickening of your, say for example, this thickening is happening in the small intestine. Over here you have inflammation of 30%, so the wall is thickened. Over here you have inflammation of say 50%, so look at the thickness. So now this is narrowing the, say, the diameter of your intestine. Okay, so now this is called a stenosis, and this may happen anywhere, as I said, in your, GI tract. Okay, with Crohn's disease. Now with fistulas, what is fistulas? Fistulas, you have these abnormal tunnels which are forming. So you see your colon is connected to your ileum. This is not normal, and there is this tiny little tunnel which is forming. So there are these abnormal, say growth which is happening and which is connecting intestinal parts which shouldn't be connecting. Okay, so see, this is the normal intestine. Then you have inflammation, meaning thickening of your wall. Then you have strictures, meaning highly thickened wall. Okay, and now there is no space because the wall is so thickened. So now you have fistulas happening. So now you have content which is going directly from your, say, small intestine to your large intestine. Okay, say from the duodenum to the large intestine, or from the ileum to the large intestine. So there are these abnormal tunnel happening which shouldn't be happening. Okay, so guys, this is called as, say, Crohn's disease and its complications. So now the medical management, guys, is to do with stomy. So you may have ileostomy, you may have, say, jejunostomy, you may have duodenostomy. Stomy meaning cutting off the part which is inflamed and which has strictures, which has stenosis, which has fistulas. Okay, meaning the more complicated the case, the more likely that this part will be cut off. And then depending upon what part is cut off, you may have a bag outside. Okay, so meaning if you have, say, a large part of, and this happens either in Crohn's disease or in ulcerative colitis, depending upon how badly the part is damaged. Okay, so if, for example, if you have, say, the small intestine part cut off, all right, and if it's a major part cut off and you can't really connect the small intestine to the large intestine for the normal fecal matter to pass through the anus, you may have a ileostomy bag. Okay, so there is a bag outside of the body and the fecal matter is collected in the bag. Now remember, this fecal matter is not, say, it may not even pass the large intestine. It may directly be from the small intestine into the bag. All right. So depending upon what part is cut off, the bag may be placed. Otherwise, if it's a small part, they may remove that part and they may connect the small intestine to the large intestine. Okay, so they may remove that small intestine, that part which is inflamed and which is in a bad condition, and they may rejoin the remaining small intestine to the large intestine. But for some reason, if that is not possible, then you may have these bags. Okay. So yes, guys, it all depends upon how bad is the condition, and this is something which a doctor would only make a decision about. Okay, so as you can see, you have a hole over here, and then you have a bag. Okay, over here like this. All right, so this is basically the medical management side of things. Nutritional management of say these conditions are very complex. Okay, the thumb rule stays as always, which is if the gut is using, try using the gut to its maximum capacity possible. Okay, and if you cannot use it, then you may have parenteral nutrition, you may have enteral nutrition when the gut is being used. But basically, if you cannot meet the nutritional needs orally, then you may opt for parenteral nutrition and enteral nutrition permutations, combinations like that. I won't go into the details of this because that is more dietetic approach. Okay, so now remember guys, this is a catabolic condition. Okay, inflammation, your body cells of your intestine, these cells of your intestine, they are inflamed, they're not functioning well. It's a catabolic condition, so you may have increased protein requirements, and increased protein requirements is not only from the protein loss, okay, from the ulcerated area, but also because of treatment, medications like corticosteroids. Okay, and as you have seen in ulcerative colitis and Crohn's disease, same things you see over here, like in ulcers, peptic and gastric ulcers, same thing you see over here, poor absorption. Okay, so you have poor absorption of your, say, multivitamin mineral supplementations, okay, you may need because of poor absorption. As I said, you may see bouts of diarrhea and constipation and/or constipation. Okay, so you will see in this patient, they may have fluid electrolyte losses, mineral losses. All right, and then corticosteroid treatment will, as you know, it increases bone resorption. Therefore, you may need to supplement this with calcium and vitamin D supplementation. And of course, as you know, calcium supplementation may be needed because of poor absorption as well. Okay, omega-3 has shown to decrease inflammation symptoms in ulcerative colitis and Crohn's disease. Therefore, it could be useful. Okay, then you have the patients may need to avoid foods which are not tolerated, and say especially if you have strictures and you have fistulas and you have stenosis, then what may happen is that the patient may not be able to tolerate highly fibrous food. Okay, and foods which have tiny seeds or like stone fruits and things. See, stone fruits, at least you're cutting, you're not eating that stone fruit, like, you know, you're not eating the seed, the stone which you have in a plum, right? But for example, things like tomato or cucumber, which have very tiny seeds, which are edible and we eat it, right? So now these may also not be able to, the patient may not be able to tolerate. Okay, because guys, you have such, especially with Crohn's disease, with strictures, fistula, stenosis, you know that there is such tiny pathway, and you may see that because of this very tiny pathway, narrowing of the intestine, these kind of food materials, they may get stuck on the intestinal lining and they may create blockages. Therefore, they may create bouts of diarrhea and then constipation as well. Okay, and these individuals may not be able to tolerate highly osmolar foods and fluids. Okay, so for example, simple sugars, so say like a glucose drink, all right, or else say milk, which is osmotic in nature. Okay, why? Because this may increase their risk of diarrhea, bloating, abdominal cramps, because anyways their absorption is impaired, digestion is impaired, all right. And with strictures, stenosis, the more complicated the cases, highly unlikely that they are able to tolerate these kind of osmotic fluids. Okay, then if they have steatorrhea, meaning because of impaired absorption, if they are excreting a lot of fat, they may be put on a low fat diet, or the quality of fat may be changing, meaning they may not be put on long chain triglycerides, which requires say a lot more of digestion, meaning you have formation of chylomicrons, so on and so forth. MCTs, clinical trials have shown they are better tolerated by individuals with ulcerative colitis and Crohn's disease. Okay, and of course MCTs will also support the absorption of your fat soluble vitamins. Okay, so then fibers, as I said, especially insoluble fibers, they may be restricted with more complicated cases. Okay, so then you have, yes, generally small frequent meals are more tolerated than big meals by individuals suffering from ulcerative colitis or Crohn's disease. And then isotonic oral supplements, meaning not osmolar in nature, okay, which may cause diarrhea and cramps. Okay, they may be helpful in supporting nutritional support. So oral supplementation like this Of course, alcohol, smoking, tobacco chewing, all of this is not recommended. Caffeine and tannin, some individuals may find that their symptoms are worsening with this and they may have to avoid it. So that is again very individual, case by case dependent. All right, I have shared with you a few patient education resources in the footnote. Okay. And so what is the medical management, for example, for ulcerative colitis, for instance? So please don't try this at home. That is a big disclaimer. Okay. So basically what is done? Generally, a healthy donor is there. Okay. So who doesn't have any sort of disease, and they are generally your own spouse or say first or second degree relative like parents or brother or sister. Okay. So there, I'll just say in very, very simple terms, guys, so it will be easy for you to understand. Okay, their poop is collected. All right, when you collect the poop, the poop is dissolved in normal saline solution. Don't try this at home. Okay, it is not just the salt which you have at home for cooking. Okay, their poop is dissolved, and then through a say a sieve, a metal strainer, and that is not the sieve you use in your cooking. Okay, this is a different one. All right, through the sieve, the poop is filtered, so you have all the fecal matter on the top, and in the bottom you have a fecal slurry, meaning fecal say liquid. Now this has a lot of healthy bacteria because this poop has come out of a donor who has whose intestine is not damaged. They have a well working intestine, so they have a lot of healthy bacteria. All right. So now why do you select say close relatives and spouse? Because when you're sharing the same microbiotic environment, eating say the same food, living under the same house, sharing a lot of things in common. Okay, so basically what has been seen that the microbiota of, you share the microbiotic environment of those individuals who are living day in and day out close to you. Okay, so yes, then what happens is through say something like endoscopy, a pipe is inserted in the colon of the individual who's suffering from ulcerative colitis. Okay, and this is generally done for C. difficile infections. Okay, so ulcerative colitis, which may be caused by this particular type of say bacteria. Okay, and and as I said, this is also if you have C. difficile infections with inflammatory bowel diseases, not just ulcerative colitis, this may also work. But as you see that the max you would insert this is in your large intestine, okay, because your large intestine is the place which has the bacteria and where you have the healthy bacteria doing all of the healthy fermentation and things. All right, so yes, this is generally restricted to ulcerative colitis. Okay, so now guys, what happens, you spray the intestine of this patient with all of this healthy fecal slurry. Okay, why? Because basically it's like say spraying water on your plants. So all the healthy bacteria from the donor is now like, going into the intestine of this patient. So now the intestine of the patient has all of this healthy bacteria and a new opportunity for the patient to synthesize and generate new bacteria. Okay, so their own set of healthy bacteria and to change their microbiotic environment of the intestine. Okay, so this is called, this is a sort of a medical management. This is called as fecal transplant. All right, so this is generally done when your good bacteria has been killed because of say a lot of say Crohn's disease or ulcerative colitis that you have suffered, or the patient, sorry, the patient has suffered. And especially if the patient has frequent C. difficile infections, that is when it is done. But the best, obviously, the decision maker would be say the medical professional, okay, the doctor also, who would make a decision whether this would be useful for the patient or not. Okay. So now I just wanted to introduce you to quickly to a very new research which you may have heard, that your gut has a brain of its own. Okay, or else you have butterfly in your stomach when you feel nervous and things like that. So basically, what is this? This is talking about the gut-brain connection. Okay, so basically your brain affects your gut. Okay, and your brain affects your gut health, and your gut health affects your brain, and your brain meaning your mood swings, your say the way you feel. Okay, why is that so? This is because your gut and your brain communicates via the vagus nerve. Okay, your vagus nerve is one of the main nervous system components which connect your gut and the brain. All right. So for instance, in the brain, you have around 100 billion neurons, and in your gut, you have around 50 million neurons. Okay. So the nervous system, which is surrounding the gut, it has around 50 million neurons. Therefore, your gut has the capacity of synthesizing its own neurotransmitter. All right. And the kind of neurotransmitter your gut synthesizes or triggers is then affecting your mood health. Okay. Your mental health. So, yes, when you have a reduced functioning of vagus nerve endings, there is an increased risk of ulcerative colitis and inflammatory bowel symptoms and syndrome. So basically, guys, this is a very, very new area of research. A lot of hypotheses are there, but yet no concrete evidence, but a very new area of research. Okay, so now guys, the neurotransmitter, which for example are produced by your gut cells, okay, and there's so many microbes which are say living in your large intestine, they trigger your say neurotransmittory system of your gut to say produce neurotransmitter. And the kind of neurotransmitter, for example, your gut may produce is say for example serotonin, and which you know can make you feel nice and happy. And it can also produce things such as gamma aminobutyric acid, so GABA. Okay, this reduces stress and anxiety. But as you have seen in your diabetes lecture, your gut can also synthesize inflammatory substances such as lipopolysaccharide, all right, which is an inflammatory toxin. And if it passes your say gut into the blood, this can increase systemic inflammation. And so when you have lipopolysaccharide plus systemic inflammation, this increases depression and mental health disorders. Okay, so it is both the thing. It is the type of neurotransmitters that your gut has the independent capacity to trigger and synthesize, and the inflammatory substances that your gut may produce. Both of these in combination can affect your mood and your health. Okay, so this is how your gut can actually affect your mental health and your mood and your mental status. Okay. So, guys, yes, so basically I used to give this just for people, for students to do it by themselves because it was very simple. But let me just cover it. Okay, so it will be useful for you if I just quickly cover it. It's not very difficult. So constipation, generally it can be anywhere between say a individual going 3 times a day to 3 times a week. Okay, why just 3 times a week? Because if you have say highly professional athletes, say who are doing Tour de France, for example, and who are cycling for days, they don't have the say their system is trained in such a way that they may not be going, you know, to pass out stools like say every day. Okay, so anytime between this is say considered healthy. Okay, normal say normal stool movements. All right, normal bowel movement. But yes, constipation is when you feel bloated, you feel cramped, you don't feel that this is affecting your day-to-day life and schedule, when it is difficult to defecate, when the stool consistency is, you know, different, and I'll show you what it is painful to pass. This is when you can classify those stools as being constipated and the individual being constipated. Okay, yes, and the weightage again may vary. It could be say anywhere as little as 200 grams of feces would be considered as say healthy bowel movements. Okay, so it all depends a lot. There's a lot of individual say differences within this. Okay, then you have type of constipation. For example, you have primary, where you have, for instance, diet. Okay, so for instance, when you know that when you have a low fiber diet, low residual diet, low water intake, all of this can lead to constipation. Lack of exercise, not new to you. Laxative abuse, when there is nothing in the intestine, what are you going to poop? So yes, laxative abuse can lead to constipation as well. Okay, postponing the urge to defecate, even that can lead to constipation. Secondary causes are, it is because of some other condition. So now I have spoken about gastroparesis in your diabetes lecture. That is one of your causes. Okay, hypothyroidism. Why? Because it impacts the peristaltic movement, the involuntary movement, say of your intestine. Okay, so then you have say neurological diseases such as sclerosis. So that could also affect say or result in constipation. Pregnancy, direct effect on constipation, especially in the third trimester, when the fetus is occupying a lot more space and your intestines are pretty much cramped. Okay, then you have medications. Okay, so these sort of medications can lead to constipation. Something as simple as iron supplements also we have seen can lead to constipation. Okay, and of course, as you have seen, GI disorders are also associated with constipation. So secondary causes are anything associated with something else, like medications or with a disease condition, so on and so forth. Okay, so this is a Bristol stool chart, guys. So as you see, the work of a dietitian is not only what goes in the mouth, also what comes out on the other end. Okay, so yes, this is a Bristol stool chart, and basically you do show this chart to the patients for us to gauge what is the degree of constipation and then to identify the underlying reasons. Okay, so this is really bad constipation, separate hard lumps, versus this is like diarrhea. Okay, severe diarrhea, where it just looks like, say, a mud. Okay, so liquid mud. Right, so these are this is called as the Bristol stool chart. All right, then you have medical management for constipation is emulsifiers. All right, so like which you generally emulsifiers are not something which you very much likely find in Woolworths and all. Okay, but for example, osmotic agent, you have heard of lactidose, which we spoke about in your liver lecture. Laxative, you know, are available even over the counter. All right, and then you have enema, and you give enema, for example, in say with a medical supervision in a hospital. So enema kits are like this. This is a home kit, which is but you have enema kits which are available in hospital. So this is a mechanical way of relieving constipation, because you have say hot say warm water which is say pumped into your anus, and this will trigger peristaltic movement and it will relieve the patient from constipation. Okay, then you have, for example, dietary management, and this is not new to you, that with constipation, the first thing which everybody knows is that you need intake of fiber. So you need intake of soluble fiber, which softens your stools. Insoluble fiber, it forms the bulk of your stool. Okay, it gives you the mass, the volume for defecation. All right, it helps to pass the stool quickly through the intestine. Okay, this is the NRV for fiber intake. We have spoken a lot about resistant starch, and resistant starch also helps to relieve constipation. Okay, so it say, as I said, the structure of resistant starch with amylose and amylopectin, this definitely helps to relieve constipation as well. Why? Because it helps in the say synthesis of healthy bacteria. The more healthy bacteria in your large intestine, the more healthier is your large intestine, the easier it is for you to defecate stools. Okay, so that is your say resistant starch. Then you have diarrhea, and roughly it is, say, by the World Health Organization, the definition is passage of 3 or more liquid stools, and you have seen in the Bristol stool chart what that means per day. Okay, so the best management technique which has been seen with diarrhea is a lot of research with probiotics. So probiotics, as I've said, it is something like yogurt, which has lactobacillus inside the food. And then fermented veggies have also shown research to say manage with the management of diarrhea. For instance, where you have something like what do we say, your fermented cabbage, sauerkraut, and kimchi. All right, and the other things, for instance, you may have, say, yeast strains which have also shown good research. But do remember, guys, you have to understand what is the type of diarrhea and which management technique. For example, if it is osmotic diarrhea, and if you're giving a lot of, say, yogurt to the patient, thinking that, yes, I'm giving a lot of lactobacillus, but this may turn very osmotic in nature, and the patient may not be relieved of diarrhea. Okay, so basically you need to know the type of diarrhea for the medical management. The type of diarrhea, I have kept it as your post reading, just as an FYI. Okay, but basically over here, my intention is to tell you that there are a lot of research in the area of probiotics to address, say, management of diarrhea. There is, say, some research, but research is still ongoing in the case of prebiotics and symbiotics and its effect with diarrhea. Okay. All right, guys. So now moving further. And as you know, with diarrhea, the first thing which you may have heard even say your grandmas talk about is a low fiber or low residual diet. Okay, because as you know, fiber, especially insoluble fiber, it will say shorten your transit time, meaning the stools are eliminated quickly from the intestine. And with diarrhea, everything is passing anyways very quickly, and you want to slow that process down. So when we talk about low fiber, it is especially to do with insoluble fibers. Okay, and you have diet transition. So a person who's experiencing severe diarrhea, it is best for them not to have, say, solid foods immediately. You need a slow transition. Okay, so you may start from very, very simple foods, like, say, for instance, say just some simple rice, okay, or some, say, bread, and then going to low fat meals, and then going to and in all of these the consistency changes. Okay, so you start from some liquids to some semi-solids, or purees to semi-solids to solids. Okay, and insoluble fibers introduced later in the diet. Okay, and even LCTs introduced later. Best to do with MCTs and be safe. Okay, in your dietary transition. Sugar alcohol in very, very large amount, like your, as I said, like sorbitol, mannitol, which is present in your these gums, sugar-free gums, they can lead to diarrhea as well. Okay, so then you in very large amount. And soluble fiber, um, yes, there are research which shows that this small amounts of it may help because it increases the transit time, meaning slowly the fecal matter is passing through the intestine, and which is what you need in diarrhea. Okay, but in first cases, you do not, if there is severe episodes of diarrhea, first avoid all fibers, start with simple starches, gradually then introduce soluble fiber first and insoluble fiber last. Okay, that is how the transition works. Then resistant starch again has shown to support even management of diarrhea because it improves the say absorption of nutrients, fluids, salt, and GI motility. Okay, because resistant starch needs more time for its breakdown, so it's the food is staying in the intestine for a longer time. Okay, so basically, guys, these are roughly the management for say diarrhea. Acute diarrhea, the World Health Organization recommended management technique is your ORS solution, oral rehydration solution. Okay, so now this is a sodium and glucose solution, and this is how it looks. This is available freely or at a very, very subsidized rate in almost all developing countries, especially I've seen it a lot in India. Okay, and this is, say, mixed with water, and you take it. Okay, so this is basically how is this made, and if the mother does not have, say, access to this, we used to actually teach how to make this solution at a community level in India, in the slums of Mumbai. So basically you have 1 liter of bottle water, but over here, remember that this water has to be, say, sterile, meaning no bacterial information, bacterial contamination. So it is boiled for a specific period of time. Okay, then you have 1 teaspoon of salt and you have 8 teaspoon of sugar. And this is basically the solution which is made. And see, this is how we used to tell the mothers, it should be no more salty than tears. Okay, so basically don't add like the opposite thing. It shouldn't be like, say, 8 teaspoons of salt which you're adding, making it so osmolar and then, say, inducing more diarrhea. Okay, so yes, guys, basically this is how we used to prepare the ORS solution if this is not available for the mother. All right, or else if this is available, just have it in that 1 liter and that's it. Okay, so this will help with the fluid electrolyte balance. That is the main thing in diarrhea which we are concerned about, is fluid electrolyte balance. So this is how we are trying to address it, which is the first thing which you do when individual is having excessive diarrhea. You don't start with foods. First you manage the fluid electrolytes, and then you gradually start introducing those foods, starting from the starchy food, and then so on and so forth. Okay. All right, guys. So yes, this is it from my end. There are a couple of more slides after this. They are just telling you the types of diarrhea, just as an FYI, post reading. But this is the very last lecture. And thank you so much, guys. It was lovely having you as part of this unit. I wish you very, very best for all of your professional endeavors. All right. And if at all I can be helpful in your future careers, please do contact me. If at all, if you're planning to do a PhD, then definitely contact me. Okay, but yes, certainly I'm very happy to help if at all you think I can be helpful for your careers in the future. All right, so all the best and be good and be kind. That's very important. That's always my last message, because the world needs a lot more of kinder people, nicer people. And always remember, guys, at the end, You won't remember the number of degrees that the individual had. You will remember how the individual behaved with you. Okay, so don't stop being a nice person. That is something a person remembers for life. Okay, so yes, and I hope I can see you around in the campus. All right, hopefully COVID will not be there and we can meet each other often. Okay, so yes, that's all from my side, guys, and yes, take care and see you around, right?